Today, we're going to talk about a discussion about harm reduction. I'm going to associate with kind of what we've done and what we've learned in Cherokee over the past several years and some concepts we have there, but it's also going to, entail kind of what we want for other people to be involved in, what we think, what I'd like to hear from all the folks on here in real open discussion and some of the issues that have come up in your regions and your tribes. Because I'd really like to learn from you folks as well. Every place is unique. Every community has its own challenges. So I think it's really important that we really try to learn from one another in this, because this conversation is a very difficult one to have, because it oftentimes compromises what we believe our principles are when it comes to treating people with addiction quite often. And it makes us kind of think a little outside the box and kind of think about things from a different perspective sometimes, which sometimes can be very difficult. So I just wanted to bring that up, because I think as we go through this, sometimes we are going to kind of scratch our head and wonder why we would try something that we feel like is counterintuitive to health, or what we believe health is. But like we're going to get into here, there's a whole spectrum of that. And that's where I'd like to kind of go from there. So this talk is called Harm Reduction in Native Communities. Having a hard time viewing my whole screen. Let me see here. Sorry, guys. I have not done a webinar yet, so I'm a little confused. What is currently happening is I'm losing the right side of my screen to the video. Is there any way to get that to go away? Okay, there we go. I figured it out. All right, so starting off here, I'm talking about the harm reduction principles. These are kind of really big concepts, more from a SAMHSA definition level here. And as it reads here, harm reduction is a proactive, evidence-based approach to reducing negative personal and public health impacts on behaviors associated with alcohol and other substance use, both from an individual and a community level. What this is really kind of defined is that, you have to be, number one, you have to be proactive, which means you have to, like I was saying a minute ago, you have to really kind of expand what you believe things should always be, and you have to always think of new ways to create ways that can help with this process of trying to impact harm reduction in your communities. And the other part of which I think is really important that we sometimes overlook is that concept of evidence-based. And evidence-based really kind of surrounds the idea that we really want to make sure what we're doing, we're tracking it, and we're making sure that what we're doing either has an impact in a positive way, or if it has an impact in a negative way, then we know that we should obviously take it away. So it's a way to kind of track what are we doing, number one, and is it really having any benefit to the community? And harm reduction services save lives by using available and accessible to people, emphasizing the need for humility and compassion towards people who use drugs. This is really saying, you really need accessibility. You have to be able to have accessibility to the folks who really need it. You have to have it throughout the community. It's not just in one area, it has to be in multiple areas of the community. And so what that would hopefully do is bring in a level of compassion that goes along with that, where there's less judgment involved with how we practice harm reduction. It's a comprehensive preventative strategy. It's harm reduction as part of the continuum of care. It promotes prevention of death, injury of disease, and overdose, and prevent the misuse of substances. And, really, I think what that means is that I look at this as not at being part of the continuum of care of addiction medicine, but it's part of every part of the continuum. I mean, there's several parts in the continuum if you look at it, and we'll bring this up later in the presentation. But on every part of the continuum, I feel like harm prevention has a place. It has a home everywhere. It's not just in one part of the continuum, but it's conferences the entire continuum, if you look at it from that perspective. This is going to give some statistical information on why this concept is so important, maybe most important part of addiction medicine right now. The CDC here, basically it shows the number of deaths, and I'll show another slide here in a minute, showing the number of deaths from overdoses, drug overdoses in 2015, and now we've had a 100% increase from 2015 to 2021. And we'll talk a little bit more about why that is. And I think a lot of us probably already know why that is, but even compared to the previous year, 2020, there was a 29% increase in deaths. Well, one of the main reasons, as I was just saying, why we know this is it's because of synthetic opioids, primarily fentanyl based, which has caused a lot of overdose deaths, both in our community here and I'm sure a lot of your communities. The hard part about this, sometimes it's hard to get accurate data all the time, and provisional counts are sometimes incomplete, and the causes of death may be pending or may not be totally accurate. And from our tribal overdose rates that we look at here in Cherokee, it's complicated by the fact that we have surrounding counties and which look at autopsies and deaths in a different route than maybe how we do it, including how the state might also have their own barriers to how they count those deaths. That's important because these numbers do matter. These matter a lot because these really show the significance of what this epidemic is doing. And then the other part about this that's increased the number of the death rate as well has been the addition of psychostimulants, methamphetamine, as well as cocaine, which are oftentimes these days mixed with fentanyl as well as benzodiazepines, which people sometimes believe they're getting a pharmaceutical drug, and they're not. It's remanufactured with fentanyl in it, which has also caused a higher risk of death. This is that statistic, just kind of looking at it from this chart shows you the rise in death coming from where it was in 1999 to where it is today. And one of the interesting, I think, points on this slide that kind of shows you two areas where it really increased was in 2015, and that's when heroin made a very strong comeback. Maybe even slightly before that, 2013, 2014 made a strong comeback into our culture. And then you can see it again more recently in 2019, 2020, when fentanyl came into the communities. And prior to that, I think another reason why it's important to look at this graph is from a harm reduction standpoint, some of the things that we were doing that we've done to help treat or maybe modify drug addiction, in particular with opiates, has actually backfired a little bit from a harm reduction standpoint. And what I mean by that is we created physician databases back right around 2006, 2007 era. And a lot of the states, not every state, but a lot of the states implemented these databases, which became more popular, which could tell if people were getting prescribed opiates from multiple providers. So it kind of helped kind of police, if you will, how people were getting prescriptions. And then the other factor there is several of the what we would have called pill mills in the past, where people would have gone and got pharmaceutical drugs from certain states and certain pharmacies and certain clinics, also became, they did away with them based on the pressure from governments and everything else. Now that sounds on the surface, both those ideas sound great for drug prevention, but it actually increased the use of illicit non-pharmaceutical medications, which entitled medications like heroin and fentanyl and street drugs. And we don't know what's in these drugs. We don't know the amounts that's in them compared to pharmaceuticals. So that had a real impact on the death rate here, as you can see in this slide. So I just wanted to bring that up because, like I said, some of these conversations are difficult because you start looking at it like, oh, we're really helping the situation. But in the big picture, if you look at it from a harm reduction standpoint, that can be difficult to say that because we've had a major increase in death rates since we've gone away from pharmaceutical opiate use, illicit pharmaceutical opiate use. This is some of the harm reduction strategies that we have here. And I just some things to think about. I'm going to kind of dive into these a little bit more as we go through how these impact us here in our community. But I did want to mention some of them here to kind of get an idea of what we're talking about. The policy changes within tribal government, tribal courts, the police, the jails, and the healthcare system all have a direct impact on how we view harm reduction. And that's really important because that really tells us, like, if we step back and we look at the community, there's opportunities across the board in the community where we can take a different viewpoint on harm reduction. especially if we're really trying to get to the concept of what are we trying to do here, which is hopefully prevent deaths of our tribal members in our community. So education offered to individuals throughout the community also is very important, meaning that you want to allow people to have education both about addiction, but also about overdose and how they can prevent themselves from overdosing. With having Narcan kits available and having different things you can have available, fentanyl test strips, things you can have available in the community that you can get at different levels of the community. They don't have to be all in one area. So that's a big part of it too, the accessibility part. You want to have, this is another important concept, staff assessment tools and trainings for all employees working within the addiction continuum. A lot of people, we carry our own biases and not even realizing the biases that we carry with us based on our own personal experiences, based on our spiritual religious beliefs, based on our own moral and ethics. And sometimes that plays over in how we treat people and how we deal with people who are in the addiction community. So by taking these staff assessment tools and having trainings, you actually realize some of the issues that you have going into it, and it allows you to work through those, which is very important for people who are working this continuum. Because really what you're trying to ultimately do is come down with a non-biased approach to how you're treating these folks. The other part here is to open the access, as we were talking about before, to both the harm reduction, but also recovery opportunities for within the community. That's another very important concept. So really the accessibility here is big. You want to destigmatize addiction through policies, education, trainings, while improving through community support. That means as we try to work through some of these concepts of harm reduction, and we're trying to destigmatize addiction, we want to do it to a point where it actually has success within the community. I mean, we want to put traction to it. And we also want to put it in the policies, because the policies are written and they hold status within how we do things moving forward. So the policies, I'm going to kind of hit this a lot of times, that concept of looking at policies within the tribe, within the healthcare system, within the courts, with all over the place, because this is what kind of helps us move forward and know what we really have to use. We want to empower people who are using drugs actively to have a real voice in the creation of these programs. I mean, these are the people that it affects, right? So we need to hear what they have to say. We can't just say, well, we know what's best and we think we know what we can do here to help it from a harm reduction standpoint. No, we need to know where they're at and what really matters to them. That's a very important concept of how we do this. All right, sorry. Harm reduction, drug use. This is kind of discussing kind of more about, how people can benefit their lives, even if they still are using drugs. Meaning, like, this isn't all about abstinence or being in MAT or being in treatment. Sometimes it's about, when it comes to harm reduction, is really looking at the concepts that can really help people in their lives in real time if they're still actively using. So that means that we have to be okay sometimes with the fact that in our culture, drug use is common and it is going to be happening around us. So we have to understand that that is part of our culture. As much as we don't like it, and as much as we'd not like it to be there, it is part of the culture. So we have to come to that realistic approach, is how do we deal with this when it's there? And also understand there's a spectrum to drug use. It's complex. It's not abstinence or you're fully blown addict. It means there's a whole spectrum of that. And what's really important with that is if you start working with somebody and you see that they are improving their quality of life and they are doing better in how they're in their life, whether it's relationships, whether it's employment, whether it's different things that can help them move forward in their lives, and they are still using drugs, but maybe they've reduced the level of drugs they're using in order to function at a better level because of some of the support they've gotten. That's also a success from a harm reduction model. That's something that you have to understand, that it's not about total abstinence or being totally in treatment. And also understanding that the quality of the individual in the community life and the well-being, not necessarily sensation, like we were saying, of drug use as a criteria for success of these interventions and policies. And once again, it calls for non-judgment. It calls for resources to people within the community that they can use in order to help them assist them. So it's really about really getting them to a place where they can function and they can succeed within their lives as best they can without bringing judgment or bringing like, oh, we think you should be here, or we wish you could do better there, but kind of meeting really where they're at and trying to help them in real time with where they're going. This is some of the overdose prevention strategies. I'm sure most of you have heard of a lot of these, the syringe services program or needle exchange. That's a big one. That can also, obviously work for, helping not passing on communicable infectious diseases, but it can also help with giving access to education. So yes, as much as we like the needle exchanges because it helps with preventing, HIV, hepatitis C, potential infections you can get, bacterial infections you can get within your blood. Those are all very, very important concepts. But the other part is that it can be a gateway to potentially education or even potential, future treatment options within the community. The fentanyl test strips are very important as well. As we just said, fentanyl is the main culprit here of a lot of these deaths. So if you can find out what's in your drugs, that is a very important concept. And then widen the access to overdose reversal treatments. There's been several pushes for this, and kind of like where can you get your Narcan kits? Where can you get these things in the community? And we really disperse them in Cherokee really widely in our community, so we can get as much access to these as possible. Now, coming along with that, and as you see at the bottom here, is it's just find a designated support person to educate about bail. That means a person in your family or friend, someone who has your well-being at heart. And you want to educate them about not only what addiction is and hopefully help them understand it so they have a better way of kind of coming around to it, but you also want to educate them about how to use a Narcan kit and how to support a person if they're in what they do if someone does overdose and how they respond to that. Okay, because that can really save a life right there if they just know a few simple things they can do in that moment. Even if they don't use drugs, they have no idea about any of it, but if they have a loved one that's in need, they can be there and help them do that. And also, as I said here in the second from last point here about access to treatment for detoxification, because that can also be an acute need if someone, is in acute withdrawal, to have the opportunity to come in for detoxification or to go directly into our Suboxone or our methadone programs. Where is harm reduction needed? I kind of hit on this earlier. It's kind of needed everywhere within the community, which means you have to be able to have, that support and kind of get to that place of where the community accepts it, that harm reduction is the best way to save lives. And that's difficult because a lot of these different organizations, as you see here, between the tribe and the community, within the tribal community, within the police, the courts, jail, a lot of these people, as I said before, we have our own kind of set principles, how our own, ideals that we come into this with. A lot of this takes kind of conversations, education. It takes planting seeds about concepts that maybe don't take traction right away, but you just want to start the conversation. So some of these things are difficult to have and difficult conversations to have because not everybody agrees and people have completely different opinions on this. But that's okay because that's starting the whole conversation and move forward. And if we can just have the conversations and listen to one another, sometimes it's just a matter of planting those seeds. At some point, maybe it'll take traction. And as I'm sure most of you know in your communities, that quite often in Indian country, it takes a long time for things to take traction. And it doesn't always happen as soon as you hope it will happen or when you think it should happen. It takes a process and people have to come around to it. And it does take a while. Starting off with the top of that tribal in the community, as I mentioned, you really want to try to get a general philosophy towards addiction. What I mean by that is like, are we looking at it from a criminalistic standpoint, or are we looking at it from a therapeutic approach? And with the harm reduction, obviously you want to go more towards a therapeutic approach. You want to get away from criminalizing drug addiction and drug use. That would be that's an ideal harm reduction standpoint. But as I said a minute ago, that can be very hard to come forward on. So you have to have education and advocacy at the tribal council level. And you need to use the evidence-based addiction treatment as what you're talking about. So you actually can use some statistics and some backing to why you're where you're at with your thoughts of what we should go towards as far as the therapeutic approach. You want to promote the development of tribal policies. And I've said that word a few times already. supporting the harm reduction throughout the community. The tribal policies are really going to be, the policies in general are going to be really big, like I said, on keeping the traction moving forward in this direction. You want to look for advocates within the community to create support for changes in the current system. Now, these can be advocates from any level, right? It can be an advocate of someone who's highly respected on tribal council, who's battled addiction, or maybe has a family member who's battled addiction. It can be, anybody, any level of a tribe that can help advocate for this approach. And if you can have those people who can help speak out and they're willing to come out and talk about their own addiction, about their family members' addiction, it can have a huge effect on other people coming forward and in being willing to help and be willing to, tell their story as well. You want to reduce the stigma towards addiction by creating events promoting addiction recovery. And this is kind of that concept of trying to, heal the sick forest, because when we first come into this concept, we really had when we're trying to implement these rallies and these people to come to them and these events, we first did them several years ago. There was like hardly anybody that showed up to these rallies, very few people. But every year, as our recovery community grew and our forest got healthier, more and more people came. And we had more and more people talking. As I was mentioning those advocates in the last point, we had more people coming who are big members of the community who are telling their story. And that has so much power within the community. So now our recovery rally, has got hundreds of people there. The first few, we only had 20, 30 people who came to our recovery rally. So it does take a little time. It does take persistence and kind of moving forward. But I think if you stay the course and you realize what we're trying to do here is to promote that healing, it really does have an impact. And then as it says here, we want to increase access to overdose prevention strategies as well. Tribal court, the legal system, like I mentioned before, can have a different approaches to how they, view addiction. And sometimes it can shift. They can shift from one end of the spectrum to the other. And really what we're trying to do is make sure that we can give the legal system enough education so they understand why we believe harm reduction is so important and such an important philosophy to have in recovery and helping save lives. So, when you're doing that and you start getting some traction, you want to try, like I said, develop tribal laws to support that harm reduction model to decriminalize addiction. And that takes, like I was saying before, a lot of uncomfortable conversations sometimes, but to have communication with the judges, with the DAs, with the public defenders, defense lawyers. So everyone kind of understands why you believe what you believe, because when you come in from a legal standpoint, it's real easy to kind of look at things in a very black and white kind of mentality and not really see the big picture based on the types of cases you're seeing, based on the way the laws are written, based on a lot of factors. So you get kind of stuck in this one mode and you lose the basis of what the big picture is here, especially from our concept, from a clinical and therapeutic concept. Like I said, we're trying to save lives. That's our main goal and what we're really trying to achieve, on that level. We're not trying to, always look at things from a very narrow perspective. We're trying to widen our perspective as best we can. And then implementation, of drug court to offer addiction treatment approach versus the criminalization approach. We do have a drug court here in Cherokee. It's been very effective getting people especially into our inpatient residential program. And so we have typically over half of our beds and I'll talk about that program here in a minute, but over half of our beds in that program are from people coming directly from the jail through our drug court. So it's kind of, it really has helped. It's helped people even if they weren't totally going into it for the right reasons when they went into treatment, but going into a 90-day program, over the course of that 90 days, a lot of times it takes traction. Their recovery does, and it does change things, being in that kind of therapeutic environment versus them being still in the jail. Tribal police and detention center, educate the tribal police in their approach to dealing with people in active addiction. And this is another one of those very difficult conversations because these people are dealing with very difficult situations, oftentimes going in people's homes, seeing people who are, overdosing, seeing people who are dying, seeing some of the things associated with active drug use can make you have a really hard, difficult opinion about addiction and drug use. But I think if we can kind of, and I know from my own personal perspective, dealing with our own police, tribal police in Cherokee, they really do want to help. I mean, they really want to help this issue. They just don't always know how. And they have a hard time figuring out, well, what can I do to really impact this in a positive way? Because they feel like it's so negative. How can I impact this in a positive way? And sometimes it's just in the conversations you're having, in the way you address it, and the way you approach these situations, less judgment and less, criminalization kind of thinking, can have a really, really good impact and help out the people who are the addicted folks, and also the police officers. And I also want to say here, one of the things that's not talked about enough is the support for the police officers from a mental and emotional health. As I said, they're dealing with extremely difficult situations when they go into them, and they have to take care of themselves in order to do things like that. As we all know, as providers and as people who deal with people with addiction, it takes a lot out of you, and it takes sometimes a lot of your soul and your heart and what you're doing. And you have to be able to take care of yourself and make sure that you're really thinking about that from that level. And you also want to, develop clinical services within the detention center. That's within our jail, to promote, offer, and addiction treatment. And we've done that. We have individual group therapy in our jail. We have case management in our jail. We have peer support that helps out. We just implemented within the last few months. We've implemented Suboxone within our jail system. Those are people that are already engaged within our Suboxone program. We're kind of phasing this in, and then we are going to take people coming back from our rehab that are on Suboxone, or go from jail to our rehab, coming back into the jail, that they continue their Suboxone treatment. We're eventually going to do induction, starting people on Suboxone within the jail. And then finally, we're going to start doing methadone treatment within the jail, and start doing methadone inductions within the jail. We're doing this all as a phased approach, but as you can see, if you're treating people who are currently in the jail, and they're willing to get treatment, and you're hitting them where they're at when they're sober, they're ready, they're ready to hit treatment. They want something different in their lives because they're sober for the first time, maybe in several years. And you have this opportunity to get them into treatment. But if you don't have that resource, you're basically sending them back out to the community when they get out of jail to exactly what they came into. And that's not going to usually work out too well. And in our community here, we've had 8 overdoses since people have left in October in Cherokee, from leaving the jail and overdose within 48 hours and dying. And I'm not saying we could have prevented every one of those situations, but I think we could have maybe prevented some of them if we had the resources available. And these are just things that we have to think about. If we're thinking about harm reduction, we really need to kind of really bend into that idea that we need to allow treatment at any level. And not, even if you are in the jail and we think, oh, you did a crime, you shouldn't be offered treatment. I think it's quite the opposite. I think you should be offered treatment, as much as anybody else, because that is a point in time when you can really get some traction and really make a huge difference. And then the other thing here is direct communication. This is huge with the police department detention center, to discuss where things are at right now. This is what we've had to do. We've had to talk to them about, where our status is right now. How are things working? Is this working? Is this not working? Are things getting any better? What challenges are you having while we're trying to do these programs within your, the jail? And then ways that we can improve. What can we do to make this better? Have those discussions, open discussions, get everybody's inputs. Everybody has buy-in to what we're trying to do, versus it being kind of a unilateral approach. This slide shows the continuum of care that I was mentioning before. This kind of shows there's lots of different places within, if we're talking about treatment now, right? This is more geared towards treatment. We have the gateway into our treatment here, and I'll talk a little bit more about this in a minute, but this is the CCA, our comprehensive clinical assessment. That kind of lets us know what from our perspective might work for this particular person when they come in seeking treatment, right? That gives us a full assessment of where you're at, as far as your use pattern, as far as what's going on in your life, as far as what resources you have available to you, what you're really wanting to get out of this, what you're hoping to get out of it, you know, as far as your future goes, being in treatment and being in recovery. So this kind of opens a door. Where are we going to go from here? And that's why these arrows are kind of all pointing around to each other, because they're all connected. And, you know, the Anil inpatient, if you start at the top, our inpatient care model here, that's an inpatient psychiatric unit that we use for detoxing folks off of opiates, meth, alcohol, benzodiazepines. It also has we have psychiatry up there. It is a psychiatric unit. So any dual diagnosis, co-occurring issues, we can help treat that there. We also, I mentioned our inpatient residential, that's called Kanawodi. That is an ASAM 3.5 level of care. And I'll talk a little bit more about that in a bit. That's got that divided into two different types of treatment, which is short term, which is 90 days. I put less than 90 days, but it's actually average about 90 days, and long term, which is a total of 8 to 12 months typically. Transitional housing, this is what we might formerly, you know, have called a halfway house. That's a supportive environment, you know, helps that you have to be required to participate in outpatient care. And then it also helps with employment, schooling, education, different things you can help the person move forward in their recovery. Then the outpatient model here, we have a medication-assisted treatment. It's both with Suboxone and methadone. We have groups, substance abuse treatment groups. We have a recovery center, which I'll talk a little bit more about in a minute within our outpatient clinic. The community resources, as we mentioned, that can be from the needle exchange to different programs that we have. And then as we talked about before, the Cherokee Detention Center, we also offer treatment. Anil outpatient, this is our outpatient clinic within our hospital. It offers a wide variety of services, including a walk-in clinic, you know, and that means you can come in any day of the week, Monday through Friday, walk in and ask for services, and you will be seen by somebody pretty promptly on that day, and start the ball rolling as far as your treatment goes. We also offer individual group therapy within our program. We offer psychiatric services. There's case management. There's peer support. We offer Suboxone, MAT. We also offer methadone, OTP. And as I mentioned before, we have a recovery center. The recovery center is more of like a therapeutic living room. I don't know if anyone's ever heard of that, but it's an idea that you can come in there any time of the day, and there will be peer support folks, people hanging around there that are just kind of, you know, it's not like a set up group or set up individual session or anything like that. It's really kind of just casual. It's giving people a place to go when they're in recovery and don't want to be out in the community necessarily because they're worried about relapse. And it gives them a place to go where they can talk to somebody, hang out with somebody, maybe learn some skill-based stuff. We do have some cultural classes there. We do have different things, but it's nothing it's very like take it as you want it kind of a kind of approach. We also you know, open access, the same day opportunities I mentioned. And that's where that CCA starts, as I mentioned on the last slide, and that opens up the other treatment options. You want to utilize the recovery center as a place where people in active addiction can find resources in a non-invasive environment. As I just mentioned before, it's a place where there's no judgment, there's no set criteria what your day has to look like in the recovery center. You don't have to hang out for an hour. You don't have to, you don't do anything. You kind of take it as you want. It gives a really nice approach to recovery. And then it helps you set up direct access to other levels of care through the outpatient clinics. That opens up psychiatry, therapy, medical, dental, the emergency department, if that's needed at that time, if there's something really acute or something, you know, going on, both from a psychiatric or a medical perspective, it's all tied in. And then also the inpatient services, both medical and psychiatric inpatient services. And we also have a community-based approach. We utilize our peer support specialists to perform home visits, and they assist in helping people find resources. They're all throughout the community, driving around, finding people, not even necessarily at their homes, but finding them at their friends' places, wherever they are, and just trying to advocate for them. Tell them, hey, we're here if you need us. Not necessarily saying you should do this, you should do that, or where have you been, or what's going on. None of that stuff. Just about like, hey, are you okay? We've been worried about you. We care about you. If you want to come back, let us know, you know, what's going on. You know, can we help you with something? You need help, you know, and it's more of like a, you know, like I said, that non-biased approach And these are coming from peer support specialists. These are people who have kind of been there and done that, and they kind of understand the pitfalls. They understand the things that can happen in people's lives that can hinder their recovery. So they get it, they really get it. And so they can come at it from a completely different approach as it might come from a therapist or a psychiatrist or anybody else that doesn't have that, that been there, done that kind of approach. Next here is medication assisted treatment. This is, MAT, Suboxone. I've done another talk to some folks here on this before. And this is just really important because, this really, we know, really increases the likelihood of survival when it comes to addiction, this approach versus an abstinence-based model. Abstinence-based models do work, but they don't work statistically as well, in particular, obviously, for opiate use as medication-assisted treatment. And with this being also, Suboxone being a blocking agent, there is harm reduction in just taking it, or even getting it off the streets. There's harm reduction in it because Suboxone does block other opiates, and you can't overdose on Suboxone. So we open our access to our MAT clinic through our outpatient clinic, through our psychiatric inpatient unit, through our inpatient residential program, and the detention center. So you can start Suboxone any of these places within our system. We individualize the meetings to offer more variety available in styles of recovery. Now, meetings, I mean group therapy, group meetings for people that are within the clinic. We formally would have people in our Suboxone clinic phase through several different phases, and they would have to go to these meetings on Monday, these meetings on Wednesday, these meetings on Thursday. And they would have to stay at their same level wherever they were at. Well, that really kind of put a lot of pressure on people to have to be here at a certain time. We tied their visit to their clinic visit with the provider to the same time their group was. So there was like this kind of carrot of, okay, if you come in for your appointment for your medication, and you got to go to this group kind of thing. Well, it seemed very paternalistic, to be honest with you. And we started talking to different folks that were doing these different styles of groups, realize if you can offer people more of options to which groups they want to go to, and which days or which times, and you don't associate it with the medication visit, right, with the provider visit, but you give them more of a menu of things that they can take from it. They had a lot more success with it, and they got a lot more out of it. And it gives people more autonomy of the recovery. Where do they want to be in their recovery versus us telling them where they need to be? They can say, hey, this is more what's my style. This is where I want to go over in this group. So it gave a lot more flexibility to folks, especially with their own lives. Everyone's got schedules. Not everyone can fit into what we think your schedule should be. They might have things going on as well that might hinder them from coming to those groups. And all of a sudden they stop showing up for groups, then they eventually can't come to the clinic anymore. And you see that how a harm reduction model, that would really hurt from that standpoint. So it's really important that we kind of look at from that level. Direct referrals to other levels of care. We talked about that from the MAT clinic. If we feel like you need a higher level of care, we can refer you directly to our residential program or to the inpatient unit. If you feel like this isn't really working where we're at right now, and someone says, yeah, I think I need more help, then we can directly refer them up versus having to be a bigger process. It can be really pretty smooth. We can use this as a gateway. Weekly meetings that we have, these are meetings within the staff to discuss a variety of issues, creating barriers to individuals and opportunities for success in the recovery. This is big because this is like, where we all get together and we have these staffing meetings. These are important because we talk about some of these things and we all have different perspectives, and the therapists and the case managers and the psychiatrists and the nurses and all these different people have talked to these people at different times and different places. So we all have information that we can help put together and really kind of maybe get together people who are really struggling in the program to figure out, okay, what can we do to help these folks? And then we offer different dosing schedules, really open up our dosing schedule for both, for our Suboxone program as well, because we do what's called supervised medication administration, especially when people first start the program or if they're struggling in the program. We might have them come in daily for dosing, and that's just to make sure we're kind of keeping eyes on them. We can help them if they have any issues or help them with barriers, but it's really to kind of give them more services essentially. But by doing that, we wanted to give them more flexibility in the dosing schedule because we know that it's hard for people to sometimes come in like a 2-hour window to the hospital. So we opened up our dosing schedule quite a bit. And we also use a treatment team intervention approach with individuals who are struggling within the program. Now, this might sound like we get the person in a room, we have like a We'll have the provider, the psychiatrist, or whoever is providing the medication. We'll have the case manager, we'll have the peer support, we'll have nursing, we'll have the therapist, all the people I mentioned that might have a different perspective. We'll pull the person in a room. Sounds pretty intimidating, right? You have all these people in a room with you, and you're like, oh my gosh, what have I done wrong? But it's actually quite the opposite. It's a way to show them that we all care and we're all here for you. We just want to know what we can do to help you. So as we start talking, we just put the ball in the person's court. Like, listen, this is not us trying to be punitive or trying to get you out of here. We want you to succeed. We want the best what's for you, but we don't know exactly what's going on. And we just want to see if we can help you in some way to get your level of success up. So it's a way to kind of show people that they have all that support. It's not about like them coming in the principal's office, kind of thing. It's about having the support they need and just saying, what can we do to help you? From any level. And it's cool because these conversations typically go really great places where you start talking about things. You're like, wow, we didn't realize that was going on. And you got to deal with that. Now we get it. Now we get why you're struggling with this. And then we can have some ways to try to help that person kind of move forward through it. And then next is our OTP, our opioid treatment program. This is methadone program. We just developed this in 2020 or 2020. And we developed this in the fall, and we were supposed to be developed not until June of 2021, but we had such an increase in fentanyl deaths in our community here quickly after the pandemic started, the COVID pandemic started, and there's different reasons why that happened, and it's also related to harm reduction, but there was no access to come on or off the reservation for people that had no business coming on the reservation, meaning you didn't work on the reservation or you weren't a tribal member. So the police would stop people and say, no, you can't come on. And that prevented a lot of the drug dealers who are dealing drugs on the reservation to come on. So what ended up being on the reservation for about a 2-month period was really potent fentanyl. And it ended up killing a lot of folks in this community. And it was really detrimental to the Eastern Band. So we decided at that point that we needed to move forward our methadone program, our OTP program. So we really worked extremely hard because I don't know if anyone else here knows what it's like to start an OTP program, but it's very federally regulated. As I mentioned here, it's federally and state regulated. It's governed by SAMP, so there's a lot of regulations you have to jump through, a lot of hoops you got to go through, and the DA is closely watching everything. So you have to make sure you do it right. So we moved that forward. It was a lot of work for a lot of the people here that did amazing work to get that going. And even this program's taken a little bit of time to take traction. Methadone's got its own stigma, for people in the addiction community and people in the community in general. And so we've had to work through some of that. And that's been good too. It's been really something that we've seen that's really taken traction more in the last several months. We've had the program open now for a year and a few months. And we figured when it was open, it was just going to kind of take off, it's just so needed. And it didn't. It was slow. And it kind of chugged along for a little bit. And then gradually we had more and more people come in it. These are all high risk folks too. So some people would come in, they'd drop out, and it was difficult. So we had a lot of issues trying to get people engaged. Well, now, fast forward, a year and a half later, we have more and more people involved now, more and more people engaged in treatment that want to come in. And more people that are coming in saying, hey, all my friends are on this, and they tell me this works. This is working for them. It was developed, I said, like in the fall of 2020. It allows for greater treatment of withdrawal symptoms and cravings for individuals using high dose potent IV opiates, in particular IV fentanyl users. But we consider the medication kind of as a gateway to our treatment options, meaning like, when you come in there and you come in to get your dose for methadone, the idea was that it was like that was a starting point for you to get anything else that you might need from our programming, whether it's case management, whether it's peer support, whether it's all these different aspects of treatment that might benefit you. So the medication isn't the be all end all. It's kind of the starting point to help move forward in other areas. One of the problems you run into is opiates and other drugs can be used while on methadone. It's not a blocking agent like Suboxone. So that does create some harm reduction issues. And what I mean by that is people will continue to use fentanyl, oftentimes while on methadone, which sounds really scary, right? You're on methadone, you're already on a pure agonist medication, a pure opiate. you're taking fentanyl in addition, what we found is most people start dropping their level of fentanyl use, and we can track that over time, what their levels are doing. And then we can promote that with some positive reinforcement. Hey, look, we can see you're really improving here. Your fentanyl levels are coming down, and you're not using methamphetamine anymore. All these different things that we can kind of look at as success, but maybe not pure success, right? They're not totally off of fentanyl. They're not maybe even totally off of meth, but they're moving in the right direction. Okay. And they're moving in a direction that creates better, healthy choices. And guess what? They're still engaged in our program, which means they're still talking to people. We're still planting seeds. We're still educating. We're still offering opportunities for treatment in a non-judgmental, non-biased way. And then we also utilize the community resources to help people. And this is the reason why I put this on here, it was a really big downfall for our program was the lack of transportation we had to get to our clinic. Because in an OTP, you have to come in every day, usually 7 days a week for dosing. It's a big commitment. That goes on for quite a while before you move on to the next phase of treatment. But what we found was one of the major problems we ran into was transportation to the clinic every day. So we opened up our hours more, we expanded our hours, give people more options, but we also utilize transit passes, free transit passes. And then the Cherokee Boys Club allows us to use their vans on the weekends to transport people on the weekends when transit's not running, because transit's a Monday through Friday transportation. And then I'm at Onalanisky inpatient. This is a psychiatric unit. As I mentioned, we detox people on this unit off of various drugs, opiates, methamphetamines, benzodiazepines, or alcohol. I'll be honest, though, the majority of what we're detoxing people on these days are opiates and meth. Usually a combination of both. We use case management to determine which individuals, which direction they're going to go in their recovery. The idea of meeting a person where they're at. That is really what we're trying to develop here. What can we do? What would you want to do? Where do you see your vision of your recovery going? Whether it's, not being on medication assisted treatment, or whether it is being on medication assisted treatment, whether it's outpatient, whether it's inpatient, whether, whatever. We want to make sure we're giving you all the available resources that we can help, to be successful. Then we transfer patients people to outpatient services or inpatient residential services treatment. That's kind of what we do for that first case management piece, figure out which direction you want to go, and then we start moving that forward. We can do MAT or OTP inductions, which means we can start people on Suboxone or methadone while they're on the unit. We can assist with the initiation of available community resources. That's housing, employment, financial assistance. We can help with some of the things that might hinder them from in their recovery in the community. At least start helping that process. Assessment, treatment of psychiatric or medical needs of individuals. A lot of these folks come in, they have co-occurring dual diagnosis, different things, medical issues that have not been dealt with, dental issues that have not been dealt with. We try to start working on their health as a whole when they come on the unit. Kanawoti, this is what I mentioned before as far as our inpatient residential program. It was developed in 2018. It's a 20-bed inpatient residential program. It's located in the Snowbird community. It's one of the most traditional communities of Cherokee, but it's about an hour off of the main boundary of the reservation. But it's nice because it's in an area where it's very isolated. It's on top of a mountain. It's a beautiful spot. It really gives people a real sanctuary to go and get away from maybe a lot of the distractions that were causing them trouble in the community as far as the recovery goes. We have 16 beds that are designated to the short-term treatment programs. That's 8 men, 8 women. And then we have 4 beds, 2 men, 2 women for the long-term program. The short-term program is a 90-day program. The long-term program is up to a year. It's available to all Eastern Band tribal members, as well as other IHS eligible tribes or living within the boundary. It utilizes a balanced curriculum, variety, and Native American other components. It's 4 phases during the first 90 days of the program. The 5th phase is a long-term phase, which is subdivided into 3 separate phases within that long-term phase. The cultural influence is led by a cultural keeper with traditional teachings, talking circles, drum circles, traditional beadwork, basket weaving, and ceremonies. This is a real powerful impact. A lot of folks go there, they have not had a lot of influence from their from a traditional standpoint. So going there starts plants a seed of their own culture and their own traditions that maybe that just need to be tapped into. And that can be extremely powerful in their recovery moving forward. And so we've seen a lot of success from that part of the program. We also offer Suboxone, methadone, psychiatric services, medical dental services. And we have a really strong work program, meaning that everyone in there is involved in working up there, whether it's in maintenance, whether it's in the kitchen. There's all different jobs that we have up there that people work in. So that's a big influence of the program, is people actually work within the program as well. The Cherokee Women's Home. This was developed as our transitional housing for our women. We have not built our men's home yet. This was built in beginning of January of 2021. It's designed for women coming from inpatient residential programs and need of additional support prior to returning to independent living within the community. We allow children in this facility with additional support provided, parenting education, childcare, different levels of relationship training, things like that that can really help with folks after they leave the program. It's located near the hospital. It's required participation, behavioral health, MAT, OTP if needed, medical, dental, work, or school. And all the women that are in this program all do have jobs, are employed while they're in the program. We assist them with transportation, employment, and financial education. It's peer driven, meaning there's people that are in this home, typically at the long end of it's up to a year prior to coming out of it. But if it's peer driven, which means that a lot of people have been in it longer, have spent more time in it. So they're able to get support from people that maybe are a little further down in the recovery road that they are. So they can help advocate, they can help motivate, they can help support in a way that, it's difficult sometimes, like I said, if you're not there with them and you're not in that mode of living in a recovery mode at that point. There are rules within the home that create boundaries for healthy living. And this is something that really I think I wanted to say, because it does create sometimes we have to scratch our heads a little bit or think outside the box. Some of the times these rules that we have are a little rigid, and it seems like, we want to have boundaries because we're trying to create healthy lifestyle, but the same end of it, sometimes these rules seem a little punitive, and it feels like it goes a little bit of away from the harm reduction model. So we're always questioning these rules. We always bring them up. We question. It's just the same thing with Kanawoti, our inpatient residential program. We're always wondering, is this rule a good rule, or are we being too hard on people with this rule or whatever, even though we're trying to obviously do the right thing. But sometimes it creates that people feeling like they're being judged and they're being treated wrong. And that's been a pattern in their life of being stigmatized and being treated in that direction. So you have to be very careful with triggering that feeling that people have. And these are some of the new ideas, we've been bouncing around, for harm reduction within our community in Cherokee. And this is offering non-beneficiaries who are family members access to direct services, including Suboxone, methadone, outpatient, inpatient psychiatry, and inpatient residential treatment. Now, this is, if from, any statistic that looks at, what's a household, what's a support unit look like around a person, if you're in a relationship with somebody and they're still actively using, and you're trying to get, in recovery and trying to get your life moving in the right direction away from where you were, if you have another person who's your husband, brother, sister, maybe usually it's a spouse or someone else in the family that you're being influenced by, and they're not in treatment, it really hinders your potential to do well. So we really want to advocate for potentially people who are in the family, who have a direct living in home with these folks, to allow them to come into treatment too, because we know not only is it going to help that individual, it's going to help the person, the other person that's already trying to engage in treatment, who is the full tribal member. We want to increase resources at the detention center, and that just goes along with what I was saying before. We want to continuously have conversations with them, keep that communication open, keep talking to them about ways we can help the process, help people out. And that can be with addiction education, Narcan kits, fentanyl test strips upon release from the jail, direct linkages to services on the day of release. So we could have a peer support person go pick them up when they're released, bring them directly over to our recovery center, get them engaged in treatment that day. Because we know that first 48 hours is a high risk time. Not only because it's a high risk time they're going to go out and use, but it's a high risk time because their tolerance is really low because they've been in jail and they've probably already detoxed. So when they come out, their drug tolerance is very low. So their potential for overdose is very high. So that's why we have to be very careful in that scenario. build a homeless shelter to offer education and availability of resources for education management and treatment. This is just kind of, offering people resources. And if they're there and they're in a homeless shelter and they need that resources and they were having issues with addiction, just offer them education. Hey, did you know that you can get this resource? Did you know this was available? Those kind of things within that program. Increase access to employment and vocational training for our folks. Now, this has been a big one. It's hard to, in particular, the employment part. It's very hard to get jobs a lot of times for these folks because they have felony on the record and they have a hard time getting work. So we really want to, try to create as many resources as we can within the community that will accept people who have maybe a criminal record, who are in recovery looking for employment. And then affordable housing, obviously, this goes along with that other kind of, concept that we're just trying to create an atmosphere where people can succeed. And housing's huge. It's a really big part of this whole process, is having, a place where you can live that's healthy and not in a bad environment. Okay, well, that's it for me. I think I covered quite a bit there. I don't know how long that went on, but I feel like it went on for a while. Yes, anyone has any questions, I'd really like to open this up. I think this is a concept. I'm sure, like I said, everyone's got different things going on in their communities. And I think it's a time that, we could really kind of learn from one another, and really kind of see what we could do maybe from our different perspectives of just kind of talking like, where are we at in our specific communities. So I really appreciate everyone and thank you so much.
Thank you, Dr. Chisholm. That was a great presentation. Lots of good information there. We do have a number of comments and questions that were entered into the chat, and I am happy to go through those. But if anyone would like to ask a question of Dr. Chisholm now, please feel free to interrupt me and jump in. One of the first comments was when you were talking about evidence-based methods. And one of our audience members noted that culture is evidence-based, but we don't hear about it very often. And when trying to use the evidence-based requirements written by non-natives, this person has encountered a lot of resistance in their intertribal Native American facility relating to historical trauma that they are up against on a daily basis. Do you have any insights into how to approach evidence-based versus culture-based, or the language that you use?
I agree. That's a very difficult concept as far as always getting people to see things from a different perspective as far as cultural versus evidence-based. I think right now, we've seen it's even through cultural trauma education and through cultural-based practice, we've seen a lot more success with it. And I think you could say that is evidence-based now. I don't think it's a separate thing, but I think the acceptance of it is more what I'm hearing is the issue, is kind of how is it accepted, or how do we implement it, or how do people see it who are non-tribal, who maybe don't really get what a cultural-based model is. And I think it just comes back to that, having those conversations and those communication, even when it doesn't always necessarily seem like people are on the same page, but really continuing to set time aside and stress the importance of having cultural components to the recovery and to the harm reduction model, because we've seen a tremendous amount of success here in Cherokee from it. And we really, we continuously try to implement more because we know how much it's really worked. But I do believe if you're in kind of a combination of a non-tribal tribal organization, that could be pretty difficult because you're going to have people coming from different perspectives. And in westernized medicine, there's a lot of rigidity a lot of times to looking at things that aren't necessarily what we would consider algorithmic, evidence-based type medicine. So I don't know if I answered the question very well, but I do think that it is a difficult issue that it's going to take quite a bit of work.
Another person asked where they could order fentanyl test strips and whether there are, I gather that state laws differ on whether fentanyl test strips count as paraphernalia.
I'm actually not sure about the state to state, laws on that. I'm sure there is some, truth to that as far as the paraphernalia part of that. I'm not sure about that. I believe we get ours through affiliation with IHS. I don't know if anybody else has any better information on that but I know that we do get, I'm pretty sure we get a supply of ours from IHS. I'm not sure if anyone else has any other information on that question.
So you might ask your pharmacy, about how to obtain fentanyl testing strips. And, if you reach out to your project officer for your TOR grant, we can also help point you in the direction of some resources.
Thank you, Will. And this actually might be another question for you, Will. Someone asked if there's a federal policy that prevents medical care providers that work for federal organizations such as IHS from offering MAT when a patient continues to use marijuana. The example was a patient was released from jail after 8 months and wanted to be on the same MAT protocol that had helped him previously, but he is addicted to fentanyl, heroin, and marijuana. And he was able to be on MAT off the reservation despite his continued use of marijuana. Would providing MAT in this case can be considered harm reduction?
Oh, well, yeah, there's a couple of issues there, but I see Emery asked that question, and Emery, you can email me that so I can get a little more information from you. But, I think as far as the last question there, whether it would be considered harm reduction, I'll defer to our speaker, Dr. Chisholm. If you have someone on MAT who continues to use marijuana, and it would allowing that be considered harm reduction?
Absolutely. I mean, if you're talking about pure harm reduction, yeah, you're not going to die from smoking marijuana. You will definitely die from IV fentanyl. And that's a difficult issue. We struggle with that. We've struggled with that forever here in Cherokee, as far as people continuing to smoke marijuana. At first we really were pretty rigid about it. To be frank, we were really kind of like, this is how you should do it. You can't be on anything if you're going to be on Suboxone and all that. But then we realized that we really were losing some folks that we really could keep in treatment when we did that. So it's one of those tough ones. It kind of goes against the grain of being totally in treatment. If you're still smoking marijuana. But from a harm reduction standpoint, I think it's pretty straightforward that it definitely saves lives, keeping people in treatment, MAT treatment, if they're still smoking marijuana.
I know, there's no federal, kind of sweeping across the board federal regulation that would prevent people from providing MAT. But as you mentioned with the OTP guidelines, if this person's in a methadone program, that program kind of has the discretion to deny that person based on marijuana use. But if Emery wants to reach out, I can give you more information on that situation.
Well, a bigger issue, which I brought up during my presentation, is the use of fentanyl, continued use of fentanyl while on methadone, because it is a pure agonist. You can continue to use fentanyl while still on methadone. I do think that the marijuana issue is an issue, but this is a bigger issue because this can actually lead to death when we're talking about using fentanyl in addition to methadone. And I'll tell you, every OTP program is struggling with this. This is not unique to one area or another area. People are all doing this. And I even know people who have tried to reduce their dose so they can take more fentanyl, reduce their methadone dose so they can take more fentanyl. You know, so this is a real struggle that we're dealing with, and I'd love to hear input from anybody who you could help us on this, but we really just try to, like I said, continue to keep them in the program, try to advocate for them to take less fentanyl, and we check their levels consistently to see if they're trending in that direction. But at some point, you have to say this is not working and that we need to try another level of care, because what we're doing here, we're just promoting you to continue to take very risky behavior, which means using fentanyl, high levels of fentanyl in addition to methadone, which obviously can kill you. So that's a really tricky concept.
My name is Brandy, and if I just wanted to add a comment to that, you know, us as Native people, or as all people, as we all belong somewhere, hearing the stories was, we have lost our traditional use of marijuana. And so this, now that state and federal is slowly trying to recognize it as this an illegal, legalized substance. So I think reminding our clients that, you know, there was a time and a place, you know, way back when, before we lost the traditional use of marijuana, that it was allowable. And again, I agree with Dr. Joel and William. It's way lower of a risk than other substances. And it's, again, pushing those policies within our tribal governments, within our federal governments, within those treatment programs, is getting them our traditional knowledge of the ways, and slowly bringing back the traditional use of different herbs and things that we collect outside. Thank you. I have also heard this from our elders that, you know, that's when a death happens. That's when the police come to tribal lands, is when our communities are out of marijuana, which then allows other substance use to be on the rise. Same with all this numbers and statistics that we see towards, what is it, after 2015 to today, is how much finally the federal government, this pharmacy, whatever, FDA approvers or DEA approvers, how much they had to, look at their own doctors who is oversubscribing them, creating these pill mills, creating these fake prescriptions, including our own hospital oversubscribing them, and you know, speaking on, hey, you know, you could give this and feed this to everybody else, but not to myself, not to people I know that I care about. So it's the federal government finally getting down on that. And you see it in the substance use numbers. When they started tightening their laws or limiting their prescriptions, that's when they went sky high. Why? Because people were looking for other alternatives. Thank you.
Someone asked Dr. Chisholm what your typical time frame for getting someone on Suboxone is, whether it's done in one visit or multiple visits.
Suboxone, we tend to do very rather quickly, same day. When the person comes in, we'll do the assessment that I mentioned before, and then that will kind of say, okay, this is something that would be a good fit. And we try to get them in that day. We have a provider that could do a Suboxone induction 5 days a week, so Monday through Friday, available. It's not the same provider, it's multiple different providers, but we did just hire in our nurse practitioner who will be solely doing our addiction clinic. So we do have a person that we're going to designate that will completely be doing the addiction clinic, which will really help, I think, the consistency of how we're doing things in the clinic, for one thing. But yeah, we offer daily inductions of Suboxone. Methadone's a little bit trickier. It's a little bit more of a process to get into a methadone clinic, meaning like you might have to come the day before, get several labs done. You'll have to get a couple of assessments done that we require to get into an OTP program. It's very regulated from that standpoint. And then you might have to come, the following day to see the nurse and the provider, do the medical portion of it, and then get started in the OTP program. So OTP can sometimes take an extra day, but we even try to do those the same day if we can, but it's not always possible because there's a lot of hoops to jump through for the OTP.
You do not require medical history and lab work for the Suboxone then?
Yeah, we do, but it's not as extensive as the OTP. Our outpatient clinic is within our hospital. So we have access to our lab, everything within the hospital. So it's literally just sending them upstairs to get some blood work done and getting a urine stream, getting a urinalysis done at that point.
And someone asked, I think we have time for maybe one or two more questions. Someone asked if you can advise them as to how to convince tribal leaders that using Narcan to reverse an overdose is not promoting ongoing drug use.
Well, I mean, from an evidence-based standpoint, I think it's pretty straightforward as far as you can use the numbers on that, to show how you're saving lives with Narcan. But I think anybody who's ever been Narcan will tell you it's not a lot of fun. So I don't think it's like promoting, use of drugs. If you got Narcan, it's a pretty miserable experience. I would say that you would have to go about it and show them the evidence of like, these are the numbers of what Narcan can do as far as saving lives. And, from our community aspect, I mean, it has saved, hundreds and hundreds of lives here in Cherokee. To get them to understand it, you might want to, like I said, bring in some evidence, like when you're talking about bringing the numbers with that, which I'm sure SAMHSA could support you with plenty of that. If you wanted some, some numbers to support what you're doing. But the other part about it would be probably trying to get some support from the Lazarus Project, which also kind of allows for funding for for the Narcan kits, and they do help with that process. That's what we initially did. And they also bring in a lot of education, and they could actually have people from the Lazarus Project, come in and maybe talk with some folks in tribal council to discuss kind of how this would work and how it would be implemented in the community.
Thank you. And Harold had his hand raised earlier. Do you have a question, Harold?
Yeah, I got a question. It's more of a concern. I come off a small reservation. I work as a CPSW here on the reservation, and we've been dealing with trying to deal with a lot of overdoses here on our reservation. But my concern is that we have a small clinic here, behavioral health, and a small clinic, and our health director, the person that's this clinic is being run under, they don't believe in Suboxone. He told us that it was just another addiction, and I don't know why that is, but there's a lady that comes in from Albuquerque, runs that Ideal Option program, and she's been trying to help us. And a lot of our community members, I mean, we just, me as a CPSW, I just do what I have to do. I set up appointments online. They got an online appointment that we can do with Albuquerque. we just enter their number and then they set up the appointment themselves and then we transport them. But, you know, that's a concern of mine is that why is our health director, being against this saving people? I mean, that it seems like that's our only option right now is because of this fentanyl. This fentanyl lace. We lost a lot of people here on this small reservation, a 2,000 population reservation, and we lost a lot of our young ones to this fentanyl lace. And that's the only option we got is to help them with Suboxone and the other one, So, I don't know who to bring this concern up to, who to really talk to about this, this lady that's trying to help us has been taking it to our tribal leaders, our tribal, meetings, that whoever is going to listen, but nothing has been done yet. So that's just my concern.
I would just say, I'm sorry for your loss in your community. First off, I think we've all felt that, the loss in the communities across the board to this epidemic. I would say that I'm pretty surprised that, is this a physician or who is the medical director?
Yeah, he's a physician. He's the one that they run the clinic under his license, because of his license.
Yeah, I mean, that's I haven't heard anyone really use that terminology as far as from a medical perspective since like maybe 2005, 2006. I mean, that's pretty outdated, that philosophy. That's like, nowadays, that's like telling a diabetic they don't need insulin. That's the analogy I would use on that. I mean, that's really old school, really not evidence-based whatsoever. So, being a physician, you would think that they would understand that this is evidence-based. This is not, and that's how we usually drive westernized medicine, is by that philosophy. So I'm just a little surprised that you would say have somebody still kind of stuck in that. But like you said, you're a small tribe. You got the one clinic. Are you IHS affiliated, I'm assuming?
Yeah.
I think I would go through IHS to kind of get some traction on that if I were you, because IHS is definitely going to go with the evidence-based model, which would say that MAT would be the way to go. My opinion, I would probably talk to the medical officer in your region for IHS and talk to them about kind of what can we do here. We have a lot of people dying. We need this treatment. We know this treatment works. It's been proven medically. What do we need to do to get some people on treatment here? Because that's really, like I said, that's really old school thinking, from what we do now. So yeah, I'm sorry about that. That should really been dealt with quite a while ago.
Okay, then. Yeah, thank you. Then I guess we'll have a conversation with IHS. Thank you.
That's what I would do. Yeah.
Would you also recommend sitting down with that doctor and saying, tell me why you think that, given all the information we have currently about this, because it's rapidly changing since 2000 and early 2000s, just to kind of be respectful to him or her, and then say, are you open to learning different things? Because it sounds like you're dealing with a bias issue with that individual. And sometimes to help people out of a bias, you have to listen to their rationale and then ask them how open they are to other perspectives.
Yeah, we had a meeting. We had staff meetings, and he came to our meeting, and we sat down with him, and we went over, the overdose that's happening in the community. That like I said, the lady from Ideal Option, she said in our meeting, and then we have a nurse practitioner that's licensed to do assessments and prescribe Suboxone here on the reservation, but he didn't agree to that. So we
Yeah.
have meetings with him.
Yeah. Yeah. So you have to get his attention in a different way.
Yeah,
Yeah.
we'll keep trying though.
Yeah. I mean, you could do community-based awareness prevention. So kind of not directly confront him, but just go around and get, increase your community's awareness program. Is that Dr. Chisholm's presentation? Thank you very much for that. It's just very thorough and comprehensive and lots of great ideas. And so like where to start, and because there are a lot of communities that don't have the resources or the full picture, the full program that you presented. And maybe the first place is what I heard Dr. Chisholm say is to start having conversation with people and kind of raise awareness. Yeah, we're going to try and get access to the PowerPoint. Just FYI, we'll figure how to get that to you, because the PowerPoint is chock full of tons of great ideas to at different levels of program implementation. So that PowerPoint would be very helpful for people. So Dr. Chisholm, we want to thank you for your information and your presentation and your presence here today. It was very, very strong with the information that I received, and I'm sure other people did too. So we'll figure out how to get if that's okay, to share your PowerPoint with people that have attended. We'll figure out how to get that to other people. And then we just want to acknowledge people who put their comments in the chat box that kept our conversation going. We could probably talk about this another half hour or so, but because of time, we'll have to close it out. One thing that we do want to ask of you is to fill out our GIPRA survey that tells us if we should continue providing webinars of the level that Dr. Chisholm has provided in whatever topics you want us to address. Please feel free to Meg put that in the chat box. There's a link. I also, when I heard Lazarus Project, I went back and looked at a website for that, and I threw that in the chat box as well for you to look at. And of course, your GPOs from SAMHSA are present. Many of them are here today, and they're always available to you for consultation and support as you roll out your TOR grants. So thanks all, and I appreciate your time.
Thank you.
Have a good rest of your day.